Obesity is one of the most common conditions that we see in primary care. It affects over 40% of the United States adult population, yet there are few, if any, diseases where there's so much misunderstanding, bias, and confusion about the correct approach. Many people still think of obesity as a failure of will. It is not. Once a person has gained weight, there are hormonal shifts and metabolic alterations that lead the body to resist weight loss. I'm Dr. Neil Skolnik, and today we're going to talk about an important new international consensus statement put together by the Lancet Diabetes Endocrinology Commission on the definition and diagnostic criteria for clinical obesity. This statement has important implications for our treatment of individual patients, as well as for insurance approval for the medicines we prescribe. It is also worth paying attention to because it's a statement that has been endorsed by major medical organizations worldwide, including the American Association of Clinical Endocrinology, the American Diabetes Association, and the American Heart Association. Let's now dive in. There are two main things: that obesity should be categorized as clinical obesity or preclinical obesity. What is clinical obesity? Here I'm going to quote: clinical obesity is a condition where the risk to health associated with excess adiposity has already materialized and can be objectively documented. What does that mean? That means if someone has metabolic syndrome or diabetes or arthritis or functional limitations or other specific, objectively verifiable consequences due to their obesity, they have clinical obesity. Preclinical obesity is excess adiposity, but without alteration in body function. A person who has preclinical obesity may or may not eventually develop complications of obesity at some point in the future. The pragmatic rationale for this distinction was to create a sense of urgency in the treatment of clinical obesity and to influence both clinicians and policymakers, like insurers, to understand the importance of treating obesity, clinical obesity, aggressively. The second main point that is made in this statement is that BMI should be used as a screening tool, not a diagnostic tool, and then confirmation of excess or of abdominal adiposity should be undertaken to confirm whether a person has obesity and or where in the body that adipose tissue has accumulated. This is because the traditional BMI-based definition of obesity is just not very accurate. It doesn't differentiate between lean body mass. Remember, lean body mass is muscle, bone, and organs, and fat body mass. And it's the balance of lean body mass and fat body mass that influences future risk. Also, BMI does not give insight into body fat distribution, which is important because increased visceral fat and abdominal fat increases metabolic and future cardiac risk. The traditional definition of obesity in non-Asian adults is a BMI greater than or equal to 30, and overweight is a BMI greater than or equal to 25 to 29.9. Remember, for Asian adults, the numbers are different. The respective numbers are a BMI of 25 to 27.5 or higher for obesity, and 23 to 24.9 for overweight. Now, for any disease, accurate diagnosis is important. We'd never argue with that, and obesity is no different. Remember, the concept of BMI to define obesity was originally based on population data, but on an individual level, defining obesity solely by BMI leads to overdiagnosis of obesity in people with BMIs greater than 30 and underdiagnosis of obesity in those categorized by BMI as having overweight. This is likely particularly true for people closest to those cut points. Interestingly, a number of studies have shown that BMI has good specificity, actually better than 90%, for identifying obesity in those with a BMI greater than 30, but poor sensitivity, around 50%, meaning that many people classified as overweight by BMI actually have obesity by more accurate measures of fat body content. We now have highly effective medicines that we can prescribe for weight loss, so this makes the importance of accurate diagnosis even more important. In people with obesity without diabetes, semaglutide in the STEP 1 trial led to a mean weight loss of approximately 15%, and tirzepatide in the SURMOUNT-1 trial led to a mean weight loss of approximately 21%. These are powerful medications, which in addition to weight loss have really beneficial metabolic effects, beneficial biomechanical effects, and have positive demonstrated effects on many obesity-related complications, including cardiovascular disease, obstructive sleep apnea, and osteoarthritis. So we want to make sure that we're prescribing them for the right people. This is simple, straightforward, and inarguably makes a lot of sense. The goal of the Lancet Commission is, on a pragmatic level, aimed at helping us define the group of people who will clearly benefit the most from these medicines. The Lancet Commission recommends that BMI be used as a screening tool, not a diagnostic tool, a screening tool, and that confirmation of excess adiposity or abdominal adiposity then be done either by a direct body fat measurement, something like DEXA or bioelectrical impedance, or that anthropometric criteria, most commonly waist circumference, that's greater than 35 in women, greater than 40 in men, be used. Within every BMI category, higher waist circumference is a marker for higher future health risk. So to summarize, the Commission suggests that classifying obesity into clinical obesity and preclinical obesity allows us and policymakers to better understand the importance and prioritize treatment of those whose obesity is having current health consequences while still advocating for treatment of those with preclinical obesity. Second, screening for obesity using BMI and then using either direct measures of adiposity like DEXA or bioelectrical impedance or using waist circumference will reduce misclassification of obesity. This is a lot of new information for something that we see all the time in the office and for which most of us have a lot of clinical experience and many of us have opinions. I'm interested in your opinion and thoughts. Please leave them in the comments section below. For Medscape, I'm Dr. Neil Skolnik.